Well, good morning, everyone. Thank you to all of you who showed up this morning very early with us. And thank you to Dr. Schilaty and Dr. Kunzer who agreed to present this morning for us. For a reminder, for those of you who haven't attended a lecture before, the Rochester Marquette Challenge is a student-led organization in which we're raising money and awareness to support physical therapy research and scholarships. And before I introduce our guest speakers, I'd like to remind everyone to please keep yourself muted throughout the presentation, and we will have some time for questions at the end. So if you have them at any point, you can go ahead and put them in the chat and we will get to them at the end of the presentation. And lastly, as a reminder, we will not be awarding any CEUs for this presentation this morning, but we ask everyone in attendance to donate a minimum of $5, and I'll be putting the donation link in the chat box shortly. So with that, I will go ahead and introduce our guest speakers this morning. Dr. Kunzer is a licensed physical therapist and certified athletic trainer. He is currently the supervisor for Mayo Clinic Orthopedics and Sports Medicine in Rochester and Minneapolis, Minnesota. Corey also serves as the coordinator for the accredited Mayo Clinic Sports Physical Therapy Residency Program, as well as a mentor and faculty for the Mayo Clinic Sports and Orthopedic Physical Therapy Residency Programs. He is appointed as an instructor within the Mayo Clinic School of Health Sciences and College of Medicine. Corey completed his Bachelor of Science in Kinesiology, Movement Science with an emphasis in athletic training from the University of Wisconsin-Madison in 2003. Corey completed his Master's of Physical Therapy from the University of Wisconsin-Madison in 2005 and his Translational Doctorate of Physical Therapy through Evidence in Motion in 2015. Corey became a board-certified sports clinical specialist in 2012, and he currently lives here with his significant other and 2 sons and their dog in Rochester. And Dr. Nathan Schilaty is an Associate Consultant Research in the Department of Orthopedic Surgery and Department of Physiology and Biomedical Engineering at Mayo Clinic in Rochester, Minnesota. He joined the staff of Mayo Clinic in 2015 and holds the academic rank of Assistant Professor of Orthopedics, Physical Medicine and Rehabilitation and Physiology at Mayo Clinic College of Medicine and Science. Dr. Schilaty develops novel techniques to explore the sensory motor activity that drives muscle performance. He applies this acquired information to develop innovative technologies to prevent, diagnose, and treat injuries or movement disorders across the lifespan. His research aims to understand the mechanisms of injury to identify at-risk individuals and generate injury reduction interventions. His research emphasizes neural pathways that directly contribute to motor control and performance. In addition, he applies innovative statistical models, including machine learning, to improve injury prevention and rehabilitation. Dr. Schilaty's work will clinically translate into advancements in the treatment, diagnosis, and prevention of athletic injuries and movement disorders. So thank you both for joining us this morning, and I will turn it over to you guys.
Muted. Thank you, Haley, and thank you for the kind introduction. And this morning Corey and I had determined that what we thought would be a great discussion is showing what kind of research we're performing here at Mayo Clinic, but then also how that can actually translate to practice. So I'll share my slides here. All right, even though we've checked, it's just a thumbs up confirmation, you can see it.
Sounds good, Nate.
Right on, okay. So a quick overview of what we'll be looking at is that there are multiple projects with which our group has been involved with, one of the primary ones being ACL injury. And so we'll cover some of that, but in addition, we've done work with concussion, lower back pain, shoulder instability and dislocation, how to improve posture and overall wellness, as well as healthy living and longevity. So a lot of the biomechanical data that you see can be translated in a multifactorial way. In a lot of ways, you got to remember that these biomechanical variables and or just our body movement, kinesiology in general, is part of life, right? Movement is what keeps the body alive. And so that movement is translatable to the work that you do as a physical therapist, or really any practitioner of the neuromusculoskeletal system. So keep that in mind that the information, the techniques that we discuss and or utilize does have that translatability, and that's what we hope to communicate today. So hopefully you weren't eating breakfast, but start off strong with a cadaveric study. But we have a unique system here at Mayo that we developed, which is a cadaveric impact simulator. And basically the issue that we knew existed was that when there is an ACL injury, these are kind of a once in a blue moon event. Even though they are very detrimental and serious injuries, it's hard to know when exactly they happen. And when they do, very often there's not video capture of it, although that's increasing now with the increased use of video. But ultimately, we don't know what kind of loads are occurring on the ACL during injury. So we wanted to look at a way to basically evaluate this in a laboratory environment and determine what exactly is going into these injuries and what is driving them. So to start this study, we actually did 3D motion capture on 44 athletes that were anywhere from 14 to age 30. And from their 3D motion capture, we were able to do the inverse dynamics and determine the external loads that were occurring on the joint. From there, we transferred that information into a system of pulleys, which you see here, and we instrumented the cadaveric specimens, and we limited our specimens to age 50, because we know that the ligamentous tissue is going to change dramatically above that age. So what we've done is we've instrumented the leg and we've dissected it down, potting the femur. You can kind of see at the on that top right image where it's potted in kind of that pink resin. And that allows it to be inserted into a 6-axis load cell, which is going to be on the inferior portion, which you can see on this lower part here. And then we instrument the muscles into pneumatics and we apply loads, and that allows us to then put the leg inverted into the load cell and then simulate a drop landing as an athlete would have during a normal athletic event. So you'll notice that we invert the leg because it's easier to drop the weight to simulate the ground rather than drop the leg onto the ground with all the instrumentation. Slide didn't advance for me. Let's see what we got. Oh, there we go. We're just going a little slow here. Okay, so here's a video of the impactor. And hopefully that's coming through okay. But basically what you can see is the weight drop comes down, impacts the leg, giving it the impact as it would in a double leg landing. And you can see the pneumatics that applied the loads that allowed it to go into the position. Now, these loads, once again, were from in vivo athletes that we had captured previously. Now, this work was interesting because as we analyzed the ACL and MCL strain with various sensors, you can see that there's a huge amount of repeatability in these impacts. And the difference that you see with the MCL and the ACL, the blue lines are the events that were non-injurious, meaning that they had a typical landing, but the loads were different because we supplied a randomized load based on the criteria from those in vivo subjects. But then the red line is the event at which injury occurred. And you can see how dramatically different that load is both on the ACL and on the MCL. And then the type of ruptures, excuse me, the type of ruptures that we're able to produce in the mechanical impact simulator are those which you would typically see in the presentation in the clinic. And so you can see a full femoral avulsion, some mid-substance tears, and also a tibial avulsion demonstrated here. And then this is another video. What we did is we actually put fluid back in the knee as you would during an arthroscopic examination. And our orthopedic surgeon was just in awe and excited that this type of mechanical simulation was mimicking what he termed an exact replication of what he sees in clinical presentation. So that was exciting for us, and this actually developed a lot of publications looking at the specific mechanisms that drive ACL injury, looking at all the factors of knee abduction, anterior shear, internal tibial rotation. And I could spoil the story, but I think maybe it'd be best for you, if you're curious, to go and look and see what kind of data is shown from this information from this mechanical impact simulator, and see how it applies and how it actually also shows maybe some of the evidence that you see in the clinic as well. Now from that, I wanted to apply a linear discriminant analysis, which is a multivariate nonlinear, well, this one is linear, but a system in which it will classify all the variables that were being recorded. So what you can see here is a list of demographics and external loads, kinetics at initial contact or throughout the trial, as well as ligament strain, and wanted to determine if we could actually predict the type of injury outcome. So with all of these specimens, we had isolated ACL injuries, there was ACL and MCL injuries, there was the terrible triad with the meniscus included, and then there was just an MCL injury and just a meniscus and an ACL. So there were 5 different presentations that came from the outcomes of the 55 specimens that we had tested. And what was interesting is that we did an initial bootstrap partition out of all these factors, and you have a 5-factor, 10-factor, and 15-factor model that came out. Now, the reason why we stopped at 15 factors is thereafter, you didn't really get much gain from adding more variables into the system. But what you may notice real quickly here is that there's some forces here on the knee that you would expect to actually create some type of either ACL or MCL injury. And then as we put it into the model, what's interesting here is this plot on the bottom is called an ROC curve. And basically it's that diagonal line that you see in the middle is what represents a coin flip, a 50-50 chance. So let's say a patient came in and you didn't want to do a differential diagnosis. So you flip a coin and you say, yep, they've got an ACL injury. Well, you know, half the time you might be right and half the time you might be wrong. So the ROC curve shows that as you go up to this top left corner, you get better resolution, if you will, less misclassification, higher sensitivity, and higher specificity. So you can also use what's called a confusion matrix, and you can see the 5 different injuries here that we had. And a confusion matrix shows the diagonals. The higher the values in the diagonal, the better the model is. So you can see that the predicted ACL was 11, and there were actually 11. But there were also 3 that were predicted as an ACL, but they also had an MCL involved. So it was a miss on these 3, but a correct hit on these 11. So you can see that the 5-factor model did pretty well, but it misclassified 38% of the injuries. When we put in the 10 factors, now we only misclassified 18%. And you can see on that confusion matrix, a lot better resolution right down those diagonals. And then finally, with the 15-factor model, we only had a 6% misclassification rate. And you can see how well this model could predict the injury outcome based on the factors that it brought into the model. And you can see this ROC curve showing that almost right angle on most of these classifications here. So we were really excited about this, and this gives information leading to the fact that we can use artificial intelligence or machine learning algorithms to use some of this data that we get in the clinic and actually start driving injury prevention and also better rehabilitation. Because if we could know which individuals are at high risk for ACL injury, then we can target those individuals for therapy beforehand in hopes of preventing the injury. Previously, it was published that you'd have to actually treat or train 110 or 118 athletes in order to reduce one ACL injury. So that's a significant burden on training and also on just the trainers in general, right? So if we can predict better who is at high risk, then we can train fewer people, but get a better bang for the buck, if that makes sense. So that's kind of what this model suggests and what we're aiming for with these future model developments. Now, shifting gears a little bit, but also working with the ACL, we had a project in which we were looking at the neural control and ultimately arthrogenic muscle inhibition that occurs with ACL injury. So when an individual gets injured with their ACL, we notice that there is some quadricep inhibition, sometimes hamstring inhibition, and also some atrophy of the muscle long-term throughout rehabilitation timeframe. So this technology, known as Decomposed Emg, allows the EMG that's on the surface to actually decompose with machine learning algorithms to the individual motor units that are actually firing. And that's the waveform that you see here on the left. It also goes through the process 2 times and compares the accuracy, and we reject anything that's below a 90% accuracy. But basically what you see on this contraction here on the black line is that it's an isometric contraction. They ramp up and they hold, and then they ramp down. And each of these circles represents when one of these motor units that was identified was recruited. And you can see it's firing spike rates here with these spikes across the line. And then you can also see when the motor unit was de-recruited. And it has what's called a onion skin relationship, in which the units that come in first are also the last ones to leave, and vice versa. But they also undergo a type of acceleration. So you can see the units when they're first recruited, they're firing, but not very fast. But then one thing that our body can do is, instead of recruiting another unit, it can accelerate the firing rate, and that will increase the force on the muscle. And you can observe that with this decomposed EMG. Now, we window it from in that middle range from 7 to 15 seconds, and we get all the statistics from all of the data that comes from here. And on the left-hand side, you can see the electrodes attached on the quad, the vastus lateralis and the vastus medialis, as the individual sitting at a dynamometer. So here's just some data that is actually hoping to get published soon. It's just aching, it's hungry, but under the review process. But basically what I want to show you is the difference between quadriceps and hamstrings. And you can see the black line representing our control subjects, meaning they were not injured. But then the other 3 colors, red, orange, and green, the various stages of ACL rehabilitation. So red is the day before surgery, and then orange is at their 6-month visit, and green at their 12-month visit. And what you can see up on the top plot here is that the quadriceps do have an inhibition that remains even at 12 months, when they're most likely to have returned to sport. The hamstrings, on the other hand, go the other direction. They actually have a little bit of a higher level of neural control. And so that might be that the body is trying to protect the ACL with increasing the neural control on the hamstrings. Now we can divide it by the specific muscles, the VM and the VL, and the semitendinosus and the biceps femoris. You can see that largely the vastus medialis is actually recovering by 12 months, but the vastus lateralis is the one that's really driving that overall combined lower functionality. Whereas the hamstrings are both recovering, or even look more excitatory than control levels. And then with the, this is looking at motor unit size. So this is designated by the motor unit action potential. You can see the increasing slope for controls, but you can see that pre-surgery, these later motor units, as the recruitment comes to the right, so the later units are to the right, that the size is actually smaller. And you can see that happening for both the quadriceps and the hamstrings. And if we look at the individual muscles, you can see that the vastus medialis actually has a recovery at 12 months of the motor unit sizes. But once again, the vastus lateralis is the one that is not recovering in terms of motor unit size recruitment. And you can see kind of similar characteristics in the hamstrings as well.
Nathan, real quick, for the
ahead.
quadriceps, now my understanding is the vastus medialis and vastus lateralis have the same innervation. So why would they necessarily cover at different rates if they have, the same innervations?
No, that's a very good question. And I do not know the answer to that one. So maybe we can have a larger discussion at the end about that, because that is a very good question. And also another thing is that a lot of PTs will mention that it seems that the vastus medialis is the one that actually has the atrophy and is getting smaller. And some of the data we should look at with the ultrasound measures that we have is the actual girth or diameter of these muscles, because it may be that just because the vastus medialis is a smaller muscle, that the effect is more dramatic in what you see, but really it's the vastus lateralis that's losing more of the mass. In terms of firing rate, and we can go back to that one. Let's see if we can answer it. This is research, right? This is data at our fingertips. So yeah, the average firing rate is about anywhere from 15 to 16 on the vastus medialis. I'm looking at about 15 on the vastus lateralis. So an initial go at it would be that each motor unit would have the ability to either tone up or tone down its calibration, so that even though the same innervation is there as a global nerve, that the individual motor units are actually regulating what they're getting from that sensory motor loop. Once again, I'm just kind of speculating there, but it's a good question that probably remains to be answered for sure. All right, ACL epidemiology, and then we'll move away from the ACL. This is just a brief study showing all of the data that we have from what's called the Roc Epidemiology project. Looking over a 30-year period, more or less, we were able to look at second injury rates of the ACL in males and females. And what you can see here is just a dramatic difference in the curves of when there's higher risk for males versus females. And it is known that females have a higher risk during the adolescent age, and that is true. And you can see that the risk actually falls off in that late 20s, early 30s. There's speculation as to why that could be, possibly because this is during their birthing years, and consequently they're not involved in as much athletic activity as the males would be. And then potentially the spike again in the 30 to 40 decade is the weekend warriors, middle-age crisis, wanting to stay active. So just some interesting data that had come out of the epidemiology. So this is a technology that's utilized in the biomechanics lab. It's called the GOM Aramis, and it is interesting in that you put some clown paint over the soft tissue structures, and then you speckle it with black spray paint. And with that, two cameras are able to take an image, kind of like our eyes, and make a three-dimensional strain gauge purely by the video camera. And what it's basically doing is creating a whole bunch of triangulations between these black dots. And between the change of that displacement over time, you get the strain measure. And you can see the color code here on the right, and the strain that you can see coming into this ligament as it's getting pulled apart by an MTS machine. So this is obviously happening at a rate much slower than what would happen in, say, a dynamic injury, but it is a way to model what's actually occurring. It can also be used to look at graph superiority or graph augmentation. So these are studies that are forthcoming or ongoing. Some other techniques to look at the sensory motor loop is high velocity threshold to detect passive motion, which is what we abbreviated as HVTT-DPM. But basically, it's a quick perturbation to the leg when the individual is not expecting it, and you're looking at their response time and their peak torque. And interestingly, you can see that males versus females, there is a difference in both passive and active stiffness at what's occurring at that baseline muscle tone. So the passive stiffness is going to be the baseline muscle tone, whereas the active is what they can actively produce in response to it. So interesting data, still looking a lot into that type of sensory motor loop and what we can learn from it, because if we can see factors that would be indicative of a potential injury, then these are the things that you could target from a physical therapy standpoint and then measure it objectively and show that there's differences and improvements. And here's a rate of force development. So we know in this case, we're asking someone to do a full isometric contraction at their maximum effort. And what we can do here is we know that we sent a stimulus here, an arrow, if you will, to tell them kick forward. And then we can measure their amount of time it took to respond, which is about 480 milliseconds. You can look at their rate of force development as well as their average peak force, and also their coefficient of variation, how much that signal deviates. So there's a lot of factors you can get from the raw data as you look at it instead of just discrete data points. And then here's another test we've been looking a lot into and using a lot lately, in which we have an individual doing an isometric contraction. And that's the black line that you see. And the target here is only 50 newtons. So this is a very light force. But we have them in both an eyes closed and an eyes open condition. So the red and orange lines are when they have their eyes open, and the blue purple lines are when they have their eyes closed. And what you can see is that this individual has a marked difference between their eyes closed and eyes open sensory, or their perceived effort, what they're doing. And the reasoning behind that is that if you have a perceived effort different from what you're really doing, then that could, of course, lead to more forces and potentially injurious conditions, or even potentially slower rehabilitation. So there are individuals that are actually right on target with both eyes open and eyes closed, but I threw this one up here just so you could see a difference. And then this is doing the same thing, but now with the neck. And you can see there's two different groups here, a concussed individual and a non-concussed individual. Looking at those two contractions, the top and the bottom, their target is the black line. The blue ones are with their eyes closed, and the red ones with their eyes open. Just in your head, tell me which one you think is the concussed individual. And if you're guessing the one on the bottom, you are exactly right. So we see that there's some differences between these individuals. We're still analyzing this data, and so there will be more forthcoming, but it's interesting to see these deviations. This individual up on top is their matched control. So they're the same age, same sex, same sport team. So they are someone very similar to the other individual, a well-known friend. But in order to measure this, we had to get a 6-degree axis load cell on this custom device, which can be wheeled around. It's about the size of a wheelchair, a little bit taller, and we have a cool helmet that's put onto it and anchored to it so we can measure the force. So when an arrow appears, they can push in that direction, and we can measure their responses. All right, so that kind of ends what I needed to show. Corey, do you want to have some slides to share?
Nathan, maybe let's answer any questions first, about kind of some of the research before we kind of take it to, before I kind of maybe start sharing.
Sounds good. I do see a question by Lexi, and it says, do you think these patterns would change based on the PT protocol, for example, with BFR versus whatever program was used here? So I'm assuming that's blood flow restriction therapy. And Lexi, can you tell me what, I don't know what study we were looking at here. You can give me some direction. That would be good. On the AMI slide, so with the neural control DEMG. Yeah, that is very interesting. That unfortunately hasn't been studied yet, but would be an expansion study from this. Currently, I would say that we had multiple PTs and multiple orthopedic surgeons with the, I think we had 55 subjects on this study. And so there wasn't any control to actually what PT protocol they followed, although I know being at Mayo Clinic, they pretty much have a standard, but with individualization to it. So How much would it change with a different technique such as blood flow restriction therapy? I would think it might have some different changes, but once again, I'm just speculating there. So for that study, there were all types of grafts used, the majority of them being the bone patellar bone, being the most popular with the surgeons here at Mayo. Also, that's based on research with having the best longevity. But there were a few that had hamstring grafts, and there was one with a quad graft. I don't think there were any allografts. So mostly BTB and probably 5 or 6 hamstrings. So you may wager to guess, would the AMI have been a little bit more dramatic on the hamstrings had there been more hamstring grafts? I don't know. That's a good question. But this was BTB mainly. Great questions. Other questions you guys have, and I can put the slides up if I need to again.
Nathan, you're obviously here at Mayo Clinic, so I had a couple questions. One was, for everything you kind of showed, how do you determine what you are going to study, like what your research is on? Like, how do you where do those questions come from?
That is a great question. Sometimes it's just pure curiosity as we're developing on ideas that we've already started to research. So when I came into after my Ph.D., I came into a laboratory that did a lot of ACL injury work. So a lot of the research will kind of grow off of that because you have a foundation on which to build on. But there's the individual curiosity. So specifically with me, I had a lot of neuroscience background, chiropractic background, really based in the neurology aspect. So I was very curious about those neural mechanisms of what could potentially drive an injury and or improve rehabilitation. So there is that individual component. But as well, it also comes down to, I think, the relationship that we have fostered between not having a research shield that's separate or a clinician shield, but rather bringing them together and sitting next to each other, conversing with each other, and determining what is the problem, what needs to be addressed, and finding creative ways to go about doing that. And then not limiting yourselves with the technology. So you may have seen that a lot of the technology that we have is actually custom built. There are technologies that we have and utilize that, are load cells and, other research grade materials, if you will, but not limiting yourself to what's already built, but saying, hey, here's the question, how can we answer that? And if this is how we do it, can we build it and do so in a manner that's portable? And that's been huge for us in that a lot of athlete research, it needs to be portable because the athletes want to be where they usually are, out on the field at their practice. They're not really keen to coming into a downtown building and hanging out for a long time because that doesn't help them in their sport. So, that's another aspect of thinking outside the box a little bit, because we need to be where we need to be for that data collection. So, translating it not only from research to the clinic, but also translating the research at where you actually do it and how you do it.
So Nathan, the next question is, who pays for this research? Who pays for your time? Who pays for those, fancy models that you developed and the analysis? How does that happen?
Well, Corey, that was your job, I thought.
To pay for it?
Yeah, exactly. No, that's a great question as well. So that's always what we call the F word in research funding. It sometimes is hard to come by because you don't want to become the professional peddler, if you will, but it often is. But the NIH and the DoD, the Department of Defense, National Institute of Health, they tend to be major drivers of biomedical research, but you also have NSF, the National Science Foundation, and other small foundations as well. So currently we have money funneling into our group from NCMIC, which is the Chiropractic Malpractice Insurance Company. They're funding a study on posture that we're doing. And we have the NIH funneling money for ACL injury prevention, or excuse me, a targeted rehabilitation program, and also private corporations. So we have a company called Tonal that's funding a study on lower back pain and how to do better prevention of lower back pain outcomes. So yeah, where does funding come from? It doesn't just come in the door. You're expected to go grab it. And the way you do that is you have to have an idea that you can sell and that people are interested in. And so, you know, if you can be involved in research initially with someone that can you can ride their coattails, that's important because it gives you the skill set to then go out and then find that other funding you need to make the changes. So that's a very good question, but there's no solid answer because it changes from investigator to investigator, from team to team. Ultimately, and I'll just throw my own viewpoint in there, I think it would be great in the future if biomedical research is more and more funded by the local organizations or institutes at which they work at, kind of building a large endowment fund, if you will, so that there's less and less need to go to the government for the funds. And then you kind of focus on more of a local emphasis, right? So if Mayo Clinic was like, oh, we need to focus on total knee arthroplasty, then you're involved in that main event. Once again, that doesn't mean you can't have your own personal touch to it, but it gives you that opportunity to kind of grow as a team and really have an objective that you're going for.
So Nathan, then is there a emphasis or requirement on presenting and publishing the research that you are doing? Is that an expectation?
So in research, yes, as a researcher, part of your promotion will obviously be tagged to publication and or funding. So it is an important driver. However, there's multiple criteria which you can be gauged on. So it kind of depends on the group that you're in, if you will. But yes, publication and actually getting these results out is important and considered in research to be very vital, because if it's just data, like some of the data I showed you isn't published, if you were curious about it, you went out on databases to look for it, you'd never find it. So ultimately, it needs to be peer reviewed. Other scientists look at it and make sure, yeah, I agree, it was done well. I agree with your statistics and your conclusions. They may have some disagreements, you kind of rebuttal back and forth, but then once it's approved, it gets published and goes out onto public servers so that, if one of you, I'll pick on Sarah, if Sarah's like, gee, I wonder what's been done on AMI and ACL injuries, she can go look at it, and it pulls up a few of these manuscripts you can look at and see where the work is currently and where it's going, and maybe see where she can put in her own contributions as well. So that aspect of publication is extremely important.
Nathan, this Marquette Challenge is really geared towards, physical therapists and PT students. What are the avenues then, once you graduate, from PT school, and you don't necessarily have access to professors, what are the avenues, in your opinion, for physical therapists to be involved and get into clinical research? And I guess we can kind of, go from the basic level to, obviously going back and getting your Ph.D. and being a primary investigator. But in your opinion, kind of what opportunities for clinicians' backgrounds to get involved in research?
Great question. The first step I would say is curiosity. That's actually what got me to go back and get my PhD, is I kept asking questions and no one had the answers. And I finally figured out that, oh gosh, maybe that means I need to go do this. So yes, you can obviously have that type of curiosity that drives you to go back and get a research degree. But aside from that, you can be involved with it at a much lower level, if you will, but still have your clinician career. So one thing that we've tried to do at Mayo Clinic is form a program called the Clinical Outcome Research Coordinator, or CORC program, in which the PTs here would be given basically a 10% of their time to be involved in research and have a researcher such as myself be a liaison or a mentor for them. But from another standpoint, you can also have just an involvement of curiosity where you reach out and you meet the local people that are involved in research and you find out how you can be involved. And it's going to be something that you're probably not compensated for, or at least not initially, but be involved, participate, and be a contributor, either with referrals of subjects to their studies, or just whatever it is that's driving your curiosity. And if you get involved at that level, then it can grow from there. But one of the things I would recommend for sure, and one that I wish I would have been involved with more in my practice as well, is just knowing the literature better, knowing that there's articles that are being published that can answer your questions. And if you're curious, go search it out and start understanding where people are in terms of the science and building from there.
Nathan, I agree. I think the first step is definitely just being a good consumer, of the research. I don't think you have to have a PhD or be publishing research to be able to critically appraise it and hopefully, then integrate it kind of into your practice. I'm going to try to bring up, are you seeing my slides right now, Nathan?
Yeah, I see the presentation side. If I don't see the full screen.
Is this the presentation slide still?
No, just the background.
So it's not the full screen?
No, just the Mayo Clinic background. Oh yeah, that's the full screen.
Perfect. So going with this, I really enjoy, kind of Nathan's background, but I want to talk a little bit more about the translational, research. How do we actually incorporate into the clinic? So, evidence-based medicine is kind of the what we want to do. That's what we need to do as clinicians to hopefully, have the best patient outcomes. That hopefully is explicit and judicious use of the best evidence in making our decisions about the individual patient in front of me. So as a clinician, I have a list of patients today, and I want to do the best treatment for the patient that's coming in here at 8 a.m. So what I want to do is I want to integrate the individual clinical experience that I have, hopefully with the best external, clinical evidence from hopefully a systematic, research. A lot of times, and this actually is from another professional colleague, Eric Mira, who has some talks about evidence-based medicine, evidence-based practice, and sometimes always kind of referred to as a stool. But he wants to kind of make the point, and I agree, that we necessarily each of the legs of the stool should not be kind of weighted equally, but rather he kind of framed it all in a funnel. So what we really want to do is, kind of look at hopefully those three things and look at the best evidence, available in its totality. And that's where we have to really be able to analyze the evidence. Then we actually want to put it to the next funnel, which is really our clinical expertise and how we synthesize that evidence. And then lastly, we absolutely do want to inform the patients, because the patients are making the decisions. So our job is to educate the patients and hopefully the best evidence out there and what our recommendations are. But then the patients have to actually make the decision, and they're the ones that are actually giving the consent, and it's their values, their circumstances, finances that sometimes play a role in what's ultimately done. So again, it's really important that as clinicians, we clinically appraise the evidence for its validity and usefulness. You think of usefulness as also clinical availability to integrate within our clinical expertise and the patient values to apply to our practice. These are the grades of evidence, and there's lots of different grades of evidence, and it's not always possible to always use, grade A. We always want to try to use grade A first if we can, which again is just high, which again is just a level 1, level 2. So it's a lot of the randomized control studies that are really just our best evidence out there for the decisions. Sometimes we don't have that. We might go on to grade B, C, or even, expert opinion, but generally I always want to use grade A. Now, I necessarily don't always have a lot of time to, critically appraise, all the evidence. So what's really helpful here is just the APTA has some clinical practice guidelines. And these are just really helpful because this is actually where a group of experts, clinicians, all got together, spent, months, years, and just reviewed all the research to kind of develop a clinical practice guideline where they synthesize it all together, and then they actually make the recommendations for the evidence. So it's a real succinct way for me to actually find out about a topic. We actually do this here in Mayo Clinic as well. It's not quite the same level of scrutiny, if you will, for clinical practice guidelines. We don't refer to it as such. We refer to it more as an evidence-informed practice document. And this is actually is one here that our one of our current sports from 2000 to 2021, and looking at all the evidence, and subsequently based on all that MC has, then again, he puts it into the treatment interventions with the grades of levels and grades of evidence to give recommendations. And that's really helpful. So then clinicians can just be much more efficient in choosing the interventions that are in front of their patients. Now, like we talked about a little bit with Nathan, is Nathan's doing a lot of he's doing some basic science research, which necessarily I'm not going to do. But what's really kind of key then is we have our research scientists like Nathan that are doing the research. But what we want to do is we want to integrate that research, translate that research into clinical applicability, into clinical application. And that's just kind of really key. So one example, as Nathan talked about, was actually ACL. So he looked at our ACL studies. And one thing we want to look at then is how do we actually determine, how do we actually treat patients with ACL injuries, minimize the risk for injuries, get them back to full sports. So as opposed to just because I think it's some way, what we really want to do is we want to look at the evidence that's out there. And some of this evidence is done by Nathan, but also just some of the group of researchers that was really led by Dr. Hewitt over decades. So what we want to do is then take that research and ultimately kind of put together, because there's so many different tests we can use that sometimes you can definitely feel like it's overwhelming and drowning. So we want to take whatever the best evidence is out there, incorporate it, and actually kind of put it to use in front of our clinic. So this ultimately here is our return to sport criteria that we want to use. But it's really important we start with the evidence. So this is our performance testing. So we put this together over years, but again, we incorporated the basic science evidence and translated that into clinical applicability. Subsequently, our return to sport criteria for ACL specifically is full range of motion, strength and isokinetic testing, no effusion, no pain, and performance kind of measure testing, as well as patient outcomes. These are some of our basic clinical criteria that we use then for the ACL as we translated the science into our clinical applicability. So again, we're looking at range of motion, of swelling, and then this is really key too. We do our basic clinical criteria, which again is our isokinetic testing. Here we use isokinetic testing using this HUMAC norm, as well as some other strength testing. This again is how we actually use that for decisions in the clinic. So this here actually is a test of an individual here. This is at 60 beats per second after an ACL, and this was at 6 months post-operatively. What we're looking at here is a limb symmetry index of this patient. So we can see here extensors, which again are mainly the quadriceps. Now again, this is definitely not broken down to isolating the quadriceps. So I can't tell here again between vastus lateralis, vastus medialis, looking at mainly the extensors on the left side and looking at the extensors on the right side, with the power on the y-axis and the range of motion on the x-axis. The dotted line is the average. Well, the upper part here is the strongest, and this is the weakest portion. We can see though here in the quadriceps, this patient here, 6 months after testing, shows deficits about 59% in peak torque and 63% deficits of strength throughout the full range of motion. So definitely putting him at higher risk for injury. And even the hamstrings, we can see deficits in the peak torque at 31% And then also in the total work done or total strength over the range of motion at 35%. And part of that you can appreciate is because they actually have a little bit decreased range of motion by approximately 5 to 10 degrees. This is the same individual here now tested at 9 months post-op. So you can definitely see that we're getting closer where there's actually less deficits in the quadriceps, but still deficits of peak torque around 31% and total work done around 37%. We're still missing some of that end range of motion. The hamstrings are much closer, so the peak torque is actually the same. There's still 18% deficit in the total work done, mainly just because of decreased range of motion. So we want to take like the research that Nathan's doing, and we actually want to kind of say, okay, then research Nathan's doing, how do we actually make it clinical? How do we take it and apply it to the clinic to actually make decisions on our treatment and our return to sport interventions? Same thing is then we also look at the performance testing. So again, we're not necessarily doing the research, but we synthesize the research and look at what are the best decisions we can make as opposed to just opinion on getting them back. So one is Y balance, and it's looking at a difference of less than 3 to 4 centimeters. Also, a single leg hopping test. There's been numerous kind of tests on single leg hopping test. Again, comparing side to side to actually create a score looking at the limb symmetry index. And these are just some examples of the athlete performing the different testing in the clinic we want to do, because again, our goal is hopefully make that much more objective, looking at the quality and the quantity of it. Same thing for a triple hop for distance and a crossover hop. Also, then we perform a agility t-test for athletes for our ACL return to sport. And then it's also important we have patient outcomes. So we measure patient outcomes using the International Knee Disability Index, Lower Extremity Functional Scale, as well as our ACL return to sport RSI index, looking at psychological readiness. And then hopefully we incorporate that into kind of game progression. But again, just to kind of point out here, when we make these decisions or return to sport, it is all based on the research. So everything we do for our testing should fall back on the research that was performed by our colleagues previous to us, such as Nathan and the other people across the country that are performing the research, that then as a clinician, where I'm not necessarily performing the research here, but I need to evaluate that research. I need to be up to date on it, especially as new research comes out. And I have to be able to integrate that research into the patient that's going to be sitting in front of me here at 8 a.m. And that's where hopefully we want to emphasize here is just the translation of the basic science evidence and where those questions come from and how the research is done to the clinical applicability of the patient sitting in front of us from a clinician. So with that, I think as we're kind of wrapping up our talk and our time today, definitely want to open this up for any additional questions or kind of just comments that that kind of staff had. I will say I've been practicing now for about 15 years, and the research is something that I always valued, but it was really overwhelming. Coming out of PT school, we got a little bit of introduction to PT school in PT school for research for myself, but not necessarily a lot of how to kind of perform research. So the best thing we can do is not be afraid of it, but kind of figure out ways to incorporate it and to make it clinically applicable. I'll also share from my experience that sometimes with some clinicians, the further you go on your career, the more sometimes you actually end up getting away from the research that's out there, depending on the setting you're working in, because sometimes it's just really hard. And not every place you end up working at has the ability to have the three-shield approach of education, research, and clinical excellence that Mayo Clinic does. So some places you end up working on, sometimes they'll take you more further away from the research. And that's why it's really important to try to kind of have mentors, to have journal clubs, to try to kind of still be associated with APTA, so you can access clinical practice guidelines, so you can just stay on top of the research that's out there. Because as clinicians coming out now, what you don't want to do is you don't want to be practicing in 10 years the way you're necessarily learning to practice today. And that can be really challenging for clinicians out there as they get busy and have less of the resources that they sometimes have currently during PT school. So with that kind of said, we just have just a couple minutes here before we wrap up. I want to definitely kind of open it up to anyone who might have questions on basic science translating to clinical applicable research.
I see a couple questions coming in through the chat here, Corey.
Yeah, one question was kind of talking about the funnel, again, which is more of Eric Mira's term, but I like the thought process of it. But how does that work when there's conflicting, research or something new that may be kind of clinical biases? And that's kind of hard because you can appreciate I kind of come with some biases. We all come with biases in everything that we do. The first thing is you have to be aware of your bias. So it's okay to have bias. I have biases in literally everything I do, but I have to be aware of my bias and then hopefully be able to kind of help that inform my decisions with it. So I think the first thing is okay to have bias, but just to be aware of your bias. Sometimes there definitely can be conflicting evidence. So that's where hopefully you want to look at the whole total amount, of research, and definitely kind of have look at and see kind of if it conflicts, or just kind of see, kind of what you can always find a study. Maybe Nathan, you can talk about this too, but I'm sure you can always find a study that one or two studies that would conflict with the total amount of research suggesting something. So you kind of want to look at the total amount of evidence and see kind of, again, like using a forest plot almost, or systematic review to kind of really see what the total amount of evidence is showing. And you have to keep up on it because the evidence definitely changes. And we also do have to take in our patient values and patient experience, opinions into what we do. For example, a really good example of that sometimes is therapeutic ultrasound. Therapeutic ultrasound was something that, I learned a lot in PT school. I actually practiced quite a bit my first couple of years, out of PT school. I had memorized, like all the settings for 1 megahertz, 3 megahertz to tell you exactly how much it would warm the tissue up at the depth. Something I hardly ever use today in the clinic, just because, again, there's not the evidence, for it. And generally, also, we should not be using a lot of passive modalities, but active modalities, hopefully, is what we should hang our hat on. However, sometimes patients can come in, again, and say that they want therapeutic ultrasound as a part of intervention because it's successful in the past. That can be really hard because I don't want to dismiss that patient, because it's really important to create a patient alliance, to create a bond, to incorporate that patient. So generally in that case, I talk to the patient and kind of tell them that there might not be, but there is not the scientific evidence, for therapeutic ultrasound. If the patient sometimes had a really good experience in the past, I do want to take that into account. So sometimes in those situations, I may kind of tell them we'll use it for a session or two, but we're really incorporating the active evidence, and I'll show them the clinical practice guidelines or evidence-informed pathways and try to incorporate the best evidence into our further treatments, but potentially use that in a short term to create the buy-in and the patient alliance to ultimately get where I want to go. Nathan, what are your thoughts sometimes on it? Maybe if you're doing something, some research, and then you find out that maybe other places, I guess, does this happen where you're working on research here, and then suddenly maybe you find out other places are working on research, and they end up maybe you weren't aware of, they end up like publishing before you, or they have things that contradict the what you're finding in your research?
Yes, all the time. And that's an important aspect to consider, like you mentioned with the bias. Just as an example, we had, when I was coming into my lab at Ohio State, there was a study in which they were trying to figure out which exercises could prevent ACL injury. And what was interesting was that they didn't want to use the individuals that were the motor morons, if you will, right? Because they had a high risk of getting injured while they were getting their data collected. So they weren't allowed to be participants. And ultimately, it showed that there was no effect by the exercise at all. However, you have to consider how they biased the study. They got rid of that high-risk group, and they were the ones that were most likely to be benefited by those exercises. So by eliminating them, they show that the exercise meant nothing, right? So we have to consider, how do we bias the studies just from the get-go? And then when there is conflicting evidence, how can we look at it objectively and say, okay, where might they have gone wrong? Where may we be wrong? What are the differences in our demographics? And find those relationships. And ultimately, that kind of critical thinking is going to lead us to kind of the next phase. The last example I would give is that sometimes you may have a hypothesis that, you know, a certain thing is a certain way for some reason. But then when we look at it and the data shows otherwise, sometimes it's just restructuring and looking at it from a different angle. And it's not that what you were thinking was necessarily wrong. It just doesn't mean it was 100% right. So those are kind of the things we need to look for when that funnel is coming in and it looks like there's a conflict, is to look at the information and see how we can overcome the conflict by taking all the information together.
Perfect. Haley, I think we might be kind of close to time. Nathan and myself, you know, both work here at Mayo, and anyone can, you know, reach out to us, you know, just directly, you know, kind of through email, if any further questions.
Definitely. And thank you for your time today.
Awesome. Well, I just want to say thank you to you both for being here this morning and having this awesome discussion with all of us. And thank you to everyone else who has supported us this month with our lecture series. We've been able to raise over $700 with the series that we've hosted. So thank you to everyone who has showed up and donated for such a good cause. And thank you to all of our presenters. And with that, I think we will end this session. And if anyone has any further questions, feel free to reach out.